Hello, dear students, and today we had a lecture about malaria, which is in translation means, as people earlier believed, bad air. So, malaria. What you should know after this lecture, you should understand basic principles of malaria pathogenesis in the context of relevance to clinical disease and epidemiology, understand the clinical symptoms of malaria, understand the difference between uncomplicated and severe malaria, understand how to choose an anti-malarial drug, and understand where to find up-to-date sources for malaria, because resistance is growing, and when yesterday it may be one schemes of therapy, in a year or two they may change, so up-to-date information is always important. So outlined, first we'll talk about background, organism, epidemiology, pathophysiology, then clinical symptoms, differential diagnosis, and malaria in a complex emergency, who is at risk and how to choose a medication. To begin with, malaria caused by a protozoal blood parasite, Plasmodium. There are several types of Plasmodium. Plasmodium vivax avalia and Plasmodium malaria cause milder form of malaria, and a bit other is Plasmodium falciparum, because it causes much more severe forms, which is often complicated and much more often leads to death. Also, there is Plasmodium knowlesi, who also may cause severe malaria. Sometimes it's written about it in a textbook, sometimes not. Plasmodium knowlesi is considered to be more of zoonotic infection, but it may infect human too. Transmission. Transmission through Anopheles mosquito, females, and have a wide spectrum of symptoms. The most prominent is fever. Geographical distribution, usually it's spread nowadays, it's spread in tropic and subtropics, while in older days it was spread almost all over the world, because conditions for spreading malaria is just presence of mosquito, which is almost worldwide, and temperature, average temperature in the daytime should be more than 50 degrees, which in summer, maybe even in rather cold countries. I mean, like countries with moderate climate. But nowadays, due to anti-malarial campaign, due to destroying of mosquitoes' place of reproduction, due to chemoprophylaxis and other epidemiological measures, it mostly spread in tropics and subtropics. 350–500 million infections worldwide per year, and 1 to 2 million deaths worldwide per year. So how usually it happens? To begin with, mosquito. Yes, how mosquito affected? Mosquito takes a blood meal and ingests gametocytes which are in the peripheral blood of a human. Yes, so it's, if you see, it's here. Yes, then flagellated macrogametocyte with macrogametocyte and go into macrogamete. Archinet go into sporogonic or asexual cycle, is that it goes to oocyst and release sporozoites into mosquitoes' sucking apparatus. And so mosquito takes a blood meal and injects sporozoid into human. So now we talk about cycles that's more interesting for us as a clinicist. So sporozoids go to human blood, then go first to liver cells. Then infected liver cells goes in erythrocytic cycle in the liver. Yes, then it goes into schizont form and rupture of schizont, and then it go into blood stage or erythrocytic cycle. So it goes in fact erythrocytes, immature trophozoites go to immature trophozoites ring stage, then it go to mature trophozoites, and may go to schizont and rupture and cycle repeats, or goes to form of gametocytes, which is sexual form, and these gametocytes swim in peripheral blood and may be ingested by mosquito for cycle to continue. I will tell it now, and I'll repeat it a bit later. What may be special here? In treating malaria, vivax and avale, in this exerythrocytic cycle in liver, there may be additional cells, hypnozoites or bradysporozoites, sleeping cell. They may cause late recurrence of infection, late exacerbation, and also may cause like super long incubation period. Here, when we talk about peripheral blood, all Plasmodium have their sex cells like hematocytes in peripheral blood. They have a bit special structure in falciparum, so-called banana shape, and like round in other types of malaria. But when we talk about other like sporozoites, yeah, they all in cells. When we talk about, ring stage, and then hematocytes, these cells are present in all forms of malaria, and intermediate, like mature trophozoites and schizonts, present only in vivax, malaria, and avale types, because in falciparum Plasmodium, these intermediate cells, they are swimming in the, not in the peripheral blood, but in vessels of inner organs. That's why you can detect it in peripheral blood, and if you detect it, that means it's so much of them that it is definitely severe form. So in normal course of Plasmodium falciparum in tropical malaria, you may find in peripheral blood only ring stage of trophozoites and gametocytes. And then you see all the form is evidence of severe course. What's happening? So in liver stage is asymptomatic. With Plasmodium vivax and Plasmodium avale has dormant form hypnozoites that can relapse much later. This form is not killed by most malaria medications, so for these forms we need special additional drug. In blood stage, what's happening? It's symptomatic. When symptoms appear, it is a continuous circle. This will continue until medication or immune system eradicates it, usually from 1 to 5 plus years untreated. One cycle 3-4 days, except Plasmodium falciparum. So 3-day cycle for treating malaria, 4 days for quadrant malaria, or which is caused by Plasmodium malaria. For falciparum, cycle is irregular, and without treatment, usually malaria, if person will die, of course, yes, will continue. If you treat it, you will start cycle with medication. But if you don't prescribe special medications for treating malaria, there may be late relapse. But even untreated, yes, in mild to moderate form, sooner or later a person will have immunity, and his immune system will eradicate malaria and parasites, usually in 1-2 years. In Plasmodium malaria, this cycle may be much longer. It may be more than 5 years or even 10 years. So this is a specific Malarian temperature curve. So it's for treating malaria, vivax malaria. So it's first irregular temperature, prodromal, and then you see the specific cycle. Temperature, normal temperature. Febrile temperature, normal temperature. Febrile temperature, normal temperature. This cycle lasts for 84 hours, which is not 3 days, but every third day. So this 48 hours, it's not between the malarian attack, but from the start of first attack to the start of the next attack. You see, it's here in the morning. So we count, 24 hours, 48 hours. Yes, and again in the morning, 24 hours, 38 hours. So, or from the start, yes, so start here. Now it's even start in the evening, but the peak is in the morning. Start, again, start every 84 hours, cycle 84 hours, and on each third day, or we can say every other day, the temperature present. Temperature present, on the 10th, temperature absent. 11th, temperature present, 12th, temperature absent. Temperature every other day. That's virus malaria. Quartan malaria. Cycle is 72 hours. So from the start of one cycle to the start of the next cycle, it passed 72 hours. So the gap between febrile days is 2 days, not 3. Yes, every 72 hours. Yes, on the each 4th day. So we have, this is initial period, then day of the temperature, 2 days of the absence of temperature, and again next day of temperature, 2 days absent, day of a temperature. Or start, then 24 hours, 48 hours, 72 hours. Yes, each 72 hours we have next cycle. So 2 days gap, quartan malaria, 1 day gap, treated malaria. Next, tropical malaria does not have a regular cycle. So it goes wherever it's like. Yes, so we have here, it's not almost a day, but from morning to evening, more than 24 hours of gap. But then again, febrile temperature, normal temperature, febrile in the morning, then even higher, but then normalize and higher in the evening. So it's a regular temperature, which is typical for tropical malaria. So epidemicity and resistance. Previously, the basic the drug of choice was chloroquine, but now in lots of countries there is chloroquine-resistant malaria. So when you prescribe drug, first check, yes, from what country the person came or what is sensitivity in your region for the moment. So you see, so how many countries with chloroquine-resistant malaria, but still some countries still have chloroquine-sensitive malaria. And some countries have even mefloquine-resistant malaria. It's data of 20 and 10 years. Yes? So nowadays, when 12 years passed, resistance, this map may change. But I don't think anybody was working with malaria in COVID period, but still, maybe something before COVID. Malaria falciparum, yes? Estimated percentage of malaria cases due to falciparum is the highest in Africa. Yes, there are some cases in South America, in Asia, but most cases is Central Africa, or just not even Central, just Africa. Well, maybe up to 75, 100%. It's African thing. So chloroquine-resistant Plasmodium falciparum overlap with exceptions. Central America was the Panama Canal, Haiti, Dominican Republic, Middle East, and a mixed infection possible in Asia. When, again, if a mosquito bite a person, it may have, or several mosquitoes bite a person, yes, a person may have several stems at the same time. He may have like not one type of malaria, but several types of malaria at the same time. And this mixed infection is possible in Asia because they have Falciparum area plus vivax area. Africa usually falciparum prevails, and in America usually Plasmodium vivax prevails. Plasmodium falciparum, dangerous. What the specificity of falciparum Plasmodium pathogenesis? So in all forms of malaria, it goes like we saw in the slide. It goes in liverins, it goes in bloods, and rupture of erythrocyte, and three typical symptoms is malarian attack, fever, chill, sweet. In also is hepatosplenomegaly and anemia. But in falciparum, there may be more severe forms, and more often it have complications. So why is it? It's in fact various stages of RBCs. That's why it don't have irregular cycle, because it don't have leading generation of falciparum, of Plasmodium. It makes RBC sticky, and it leads to sludge syndrome, which may result in severe hemolysis, so DIC syndrome, obstruction of microcirculations, and obstruction of capillaries. It's wholly hyperendemic, so a lot of people infected. But kind of good news, it does not have hypnozoids. That is dormant liver form that causes relapses in Plasmodium ovale and vivax. So it's in fact various RBC, it makes it sticky, and it multiplies in the vessels of inner organs. It's one of the additional reasons. So malaria complex emergencies. So it's maybe complicated, uncomplicated. And complicated, yes, it's basic form. Fever, but not always cyclic if we talk about tropical malaria. Yes, chill sweats. So fever, chill sweats, technically is one symptom. It's malarian attack. Headache, myalgia, which is sign of intoxication, and again close to malaria attack, because, well, if we talk about cotton malaria, in these 2 days without temperature, headache and myalgia will be absent. Diarrhea, nausea, emesis may be, and most often it's of course in tropical malaria, and is rare for other types of malaria. Anemia is constant sign for all types of malaria, but again it may be more or less expressed. Mild anemia in some kind of cotton malaria, and express severe anemia with hemoglobin less than 50 grams per liter in a Plasmodium falciparum, which needs to have blood transfusion. Thrombocytopenia maybe, and hepatosplenomegaly, again a constant sign. So three main is fever, chill, sweat, malaria, and attack, anemia, hepatosplenomegaly. Also maybe intoxication syndrome, headache, myalgia. In tropical malaria, diarrhea, nausea, emesis, which is still just clinical symptom, and thrombocytopenia may also be. In severe forms was added. To begin with, parasitemia is more than 5% of the blood, and it's really high. Anemia is severe. Yes, it may even need blood transfusion to cure it. Hemoglobinuria may be. Bleeding diathesis, shock hypotension, renal failure, which is, as you see in previous form, this obstruction of microcirculation of capillaries, may be in the kidneys, and it may lead to renal failure. Hypoglycemia may be, acidosis, and such a complication as neurologic abnormalities, which is malarian coma. It's the biggest killer, the most often cause of death in malaria. And of course, this malarian coma happens only in tropical anemia. Tropical malaria. Also, there may be a complication of cotton malaria, as these parasites live for the longest time in the body. Eventually, it may cause nephrosis nephritis due to circulation immune complexes. And in all cases, if you treat your person with some anti-malarial drug, it may cause hemoglobinuric fever, which is complication not of malaria itself, but of the treatment of malaria. We'll talk about it a bit later. Who is at risk for severe disease? Highest risk is population in non-immune person, because in endemic regions, people may have malaria several times in their life, in the childhood, and then as a teenager, maybe then as adults. If they have partial immunity or just immunity, of course, they have lower chances of the severe course. Plus, there is a vaccine against malaria, but it's not super effective. It does not prevent fully disease, but it may partly prevent in some people or prevent severe forms. So immunization also possible. Immunocompromised and malnourished person, infants, young children, and pregnant have severe course of malaria. By the way, part of the mode of transmission from mother to child, not only through mosquito bite, but also from mother to child and through blood transfusion. But it's rare because usually we check blood before transfusion, but it's maybe one of the ways. Infected with Plasmodium falciparum. Yes, Plasmodium falciparum much oftener give severe course. In endemic areas, older children and adults develop partial immunity, which I say I can have asymptomatic infection, so-called asymptomatic, or can have subacute or chronic symptoms. So they may not have malarial attack as itself, but have habeas splenomegaly and anemia. Malaria and complex emergencies. So displaced people within malaria endemic areas creates risk for a severe epidemic, particularly if the displaced persons are from less endemic area. Highlights to lowlands. Laboratory diagnosis may be impractical and may become necessary to treat some people based on clinical history and do mass fever treatment. Again, if we have some kind of outbreak in a region where laboratory studies and everything is not so easy to get, so sometimes if we talk about, again, we talk about tropics, so we may just treat people based on clinical history and just do mass treatment. And I heard from travelers, yes, they in tropical countries, they really, doctors not even test you for what type of malaria you have. You just have malaria, it may be obvious from your symptoms, and they give you some therapy. So sometimes it may be on full therapy. Yes, we'll talk about it again a bit later. So this may be. But of course, if you live in a country which is where malaria is not endemic, you may just isolate and treat person, and you have all your time to make the diagnosis and prescribe correct treatment. So practical aspect. Presumptive treatment has been commonplace for decades. It's problematic but hard to change. It's in endemic regions. Even in highly endemic countries, World Health Organization estimates 1/3 of febrile persons due to malaria. So again, like in first lecture, when we talk about tropical countries, you see the fever, you think about malaria. Anytime you see the fever, you think about malaria and you give person anti-malarial drugs. In Africa, less than 20% of suspected cases receive a confirmatory diagnostic test. Yes, so what we're talking about is in endemic countries. Malaria in a complex emergency. Important when possible to at least establish a fever epidemic is due to malaria. So do some diagnosis. Combination of rapid diagnostic test and smear to establish malaria as cause, to monitor epidemic curve. Evaluate for other disease, monitor clinical response. Because again, malaria is of course really spread, but it's not the only reason for the temperature, maybe something else. Again, so to diagnose, we may use different diagnostical tests. Again, The fastest, of course, is a rapid test. In 15 minutes, you know, is it tropical malaria or other types of malaria or not malaria at all. Usually it has 3-stripe. Control stripe, stripe for treating aquatic malaria, and a special stripe for tropical malaria, which should have different treatment. In the perfect world, we should take, of course, smears, which is golden standard. There is sick drop and smear itself, or also it's called thin drop. So, and they are needed for different purposes. In smear or thick drop, we just diagnose the type of parasite. Yes, what is it? What type? Is it Plasmodium or Vivax or Vale? For thick drop, we just try to find parasite at all, which is easier due to higher concentration in thick drop. Plus, we count the amount of parasite per field. We need to know the amount of parasite for two purposes. To think of prognosis, yes, how the high amount of parasite, the severe the case, the worse the prognosis. Plus, we can, with this way, monitor is it getting better or worse, monitor how does our treatment effective. Differential diagnosis. Malaria can involve many organs, so it's not that easy. And co-infected, but co-infection will describe. And again, malaria may be together with some other disease. So, except malaria drugs, you should maybe prescribe something else. So, differential diagnosis with salmonella typhi and non-typhi. Yes, high temperature, some vomiting, maybe, why not? Staphylococcus aureus with Falcao's bone, joint, muscle, and heart. Dengue, yellow fever, Japanese encephalitis, pneumonia, again high fever, and in malaria there may be some cough. Viral and bacterial meningitis, meningoencephalitis, especially when we talk about malaria and coma. Yes, so rather fast. In tropical malaria, it's rather fast coma may develop. So a person have high temperature, which is irregular, and then just some neurological symptoms. Of course, you can think of some meningitis or encephalitis, which probably viral or bacterial. But again, don't forget about malaria, especially endemic areas. Leishmaniasis, schistosomiasis, tuberculosis, liver abscesses, cholangitis, or oncologic process. But again, to confirm those, we have diagnosis. Rapid diagnostic test, which is on the screen here. Control and another one. Lateral flow test relies on antibody-antigen interaction. Some rapid diagnostical tests specific for Plasmodium falciparum will have organization quality assurance program underway. Clinical public acceptance large problem, USA only to confirm species and microscopy. Well, in Russia we do this. Sick for diagnosis, what I told, and thin identification and parasitemia. Placentas of parasites in RBC. Clues to falciparum. Again, trophozoites most commonly seal and are small, delicate rings, often multiply per RBC. Infected all ages of RBC. Hematocytes are banana-shaped. So in other frost of malaria, you will see young trophozoites, old trophozoites, immature and mature schizoid, and then hematocytes, all peripheral parts. But in tropical malaria, you will probably see in peripheral blood only young trophozoites and gametocytes, male and female, banana shape, and other immature and mature schizoids and old trophozoites you probably won't see, only in super severe form of malaria. Now, treatment. Okay, so it's old picture how it's used because in ancient time it was a problem, not ancient, like it's like 100 years ago, not so long time, but still it was a problem. But now, yes, technically it's still a bit a problem. So a CDC algorithm for travelers who return to US. What does it mean? It's algorithm for travelers who, again, for Countries which are not endemic for malaria. CDC now recommending treating severe malaria with artesunate, treat with autoquan proguanil until it arrives 5-12 hours to enroll a patient with severe malaria in this treatment protocol. You can contact CDC malaria hotline if you in America or speak with CDC malaria branch clinical. So, but at least you always may check site CDC Gov malaria diagnosis treatment, and I think it will be probably there with resistance according to regions. So when it's non-endemic, first you get a history of travel to malaria endemic area or clinical suspicion of malaria. So yes, if it's endemic, you will anyway check person for malaria if he has high temperature. If you live in non-endemic country, yes, you just moved or it's eradicated in your country for the moment, yes, still, you ask about travel and history. Then perform second thin blood films and read within few hours, and if blood film is positive, you calculate parasitemia and evaluate clinical status and disease severity. If blood film is negative, it's not the end, you repeat blood films every 12 to 24 hours for a total 3 sets. Because it may be low parasitemia maybe in first blood film and you may just not notice your doctor, laboratory doctor. Then if blood film is still negative, you think of some other diagnosis. Again, if it's positive and you calculated parasitemia and this is the severity of malaria, you see is it complicated or uncomplicated. If it's uncomplicated, you determine the species. If it's non-falciparum species, it may be Plasmodium malaria, quartan malaria. Then you use chloroquine or hydrochloroquine. For malaria, Plasmodium, it's quite enough. If it's Plasmodium ovale or Plasmodium vivax acquired outside Papua New Guinea or Indonesia, you use chloroquine or hydroxychloroquine plus primaquine to kill tissue forms, liver forms, hypnozoids to prevent late relapse. But you may use primaquine only if person does not have glucose 6-PO deficiency. Because if person has this disease, as answer to your primaquine treatment, he will may give you hemoglobin uric fever. And in this case, of course, the first thing you should do is cancel primaquine and then treat the patient. But first thing is cancel primaquine. Then, if it's Plasmodium vivax acquired in Papua New Guinea or Indonesia, you use autoquinolone proguanil or quinine plus tetracycline or doxycycline or mefloquine to treat erythrocytic form plus primaquine to treat exerythrocytic form. If it's Plasmodium knowlesi, you use chloroquine or hydroxychloroquine plus admit the hospital to monitor for progression or disease severity, because again we talk about Plasmodium knowlesi, it may give severe forms too. Again, it's Plasmodium falciparum or species that not yet identified, and it is acquired in chloroquine-sensitive area. Then the same species scheme is Plasmodium knowlesi, chloroquine or hydroxychloroquine, and admission to the hospital, because again, Plasmodium falciparum often have severe course. If it is acquired in chloroquine-resistant area, you give autoquilone proguanil or artemether lumefantrine or quinine plus tetracycline or doxycycline or clindamycin or mefloquine plus admission to the hospital. If it is acquired in mefloquine resistant area, again admission to the hospital plus autoquel lonprogonil, artemether, lumefantrine, well, it's the same, but except mefloquine. If it's from the start severe malaria or patient unable to take oral medication, we give intravenous quinidine plus tetracycline or doxycycline or clindamycin. If quinine is unavailable, contact CDC malaria hotline for artesunate. Again, depends, yes, it depends on the country. It's a scheme for America. Admit to intensive care unit for continuous cardiac monitoring, prevent and treat of complication. Consider exchange transfusion if parasitemia is more than 10%, or if patient has an altered mental status, ARDS, or renal failure. Switch to oral medicine to complete the treatment regimen after appropriate clinical response. And in all these cases, repeat blood films if symptoms recur. You can take World Health Organization guidance and update at its site in malaria publications part. So malaria case management operation manual, it's there. I even downloaded it myself to check what's written here, and it's with more detail. It's everything about etiology, pathogenesis, treatment. It was a big. Plus, for the moment at the university, you may use our short short manual book for tropical disease, which is malaria also written, but just shorter. Again, malaria therapy options. AST, which is artemisinin-based combination therapies, especially it's used for tropical malaria. The failed AST in the interagency emergency health kit should be artemether lumefantrine, which is Quartem. Artesunate, it may be artesunate plus amoquinine, artesunate plus mefloquine, artesunate plus sulfadoxine permetoprine, and is not used for Plasmodium vivax. Also, it may be artesunate doxycycline or clindamycin, dihydroartemisinin plus piperacin, quinine plus doxycycline or clindamycin, autoquine plus proguanil, mefloquine, chloroquine, widespread resistance for the moment but still used in some regions, primaquine, kills liver phase for Vivax and Ovale, intravenous intramuscular artesunate or artemether quinine may be given, and even artesunate may be given in rectal forms. So again, repeat, suspected malaria, blood films, or rapid test if available. If it's negative, repeat it 12-24 hours for 3 sets. And if it's positive, calculate parasitemia and categorize as a complicated or severe. If it's not available, evaluate probability based on local epidemiology. Decision to treat, decide what severity and treat. Decision not to treat, re-ISIS every 12-24 hours, evaluate alternative causes. Yes, so maybe to see if new symptoms appear, or you find the real reason of this disease. Uncomplicated malaria treatment. Again, if possible, by epidemiology or SMED to understand is it falciparum or not. If it's positive and possible, use local resistant patterns to choose medication. It may be or AST or artesunate plus tetracycline, doxycycline, clindamycin, quinine plus tetracycline, doxycycline, clindamycin, autoquine plus proguanil, mefloquine, quinine, doxycycline, redose if emesis within 30 minutes. And consider admissions to monitor disease progression. Then use local resistant patterns if not available to choose medication. Chloroquine or AST, hydroxychloroquine, autoquine, proguanil, mefloquine, quinine, doxycycline, redose if emesis within 30 minutes. If Plasmodium vivax avale and patient has not G6PD deficient, treat with Primakin. Specific dosage and length of treatment, again, you may find on the CDC site, on the World Health Organization site, and in our short manual book to prepare for the class. Again, specific dosage you may find there. For the moment, we just discuss common things. Again, criteria of World Health Organization for severe malaria. One or more of the following clinical features: impaired consciousness, prostration, a sign of starting coma, failure to feed, seizures, respiratory distress syndrome, circulatory collapse, clinical jaundice plus evidence of other vital organ dysfunction, which is maybe jaundice, gross hemoglobinuria, abnormal spontaneous bleeding, pulmonary edema, which may be diagnosed radiologically, laboratory findings, hypoglycemia, blood glucose less than 2.2 millimole per liter, metabolic acidosis, plasma bicarbonate less than 15 millimole per liter, severe nomocytic anemia, hemoglobin less than 5 grams per deciliter, packed cell volume less than 15%, hemoglobinuria, hyperpositemia more than 2%, 100,000 milliliter is low intensity, and transmission area or more than 5% or 250,000 in area of high stable malaria transmission intensity, hyperlactemia, lactate more than 5 millimole per liter, renal impairment, serum creatinine more than 265 millimole per liter. Severe malaria, admittment the same regardless of species. Therapy plus supportive care. Intravenous medication. If it's available, treat intravenous 24 hours minimum artemisinin intravenous or intramuscular artemisinin quinine. Then also we use ongoing supportive care, including evaluation for blood transfusion, treatment for co-infection, treatment of seizures. This treatment follow with full course of oral antimalarial AST, artesunate plus clindamycin or doxycycline, quinine plus clindamycin or doxycycline. And if it's severe but illness is caused with Plasmodium ovale or vivax, follow with Primakin, yes, to kill liver 4, but if person does not have G6 PD deficient. If intravenous medication is unavailable, give oral or rectal until patient can be transferred to a referral center. Rectal artesunate quinine, intramuscular artesunine, intramuscular artemether, intramuscular. Again, prevention of malaria. Bad nets if you in local, in endemic area. 1,000 nets may save 5 lives. Insecticide impregnate best. Cochrane review of 2009. Indoor personal insecticides, so or indoor different apparatus or just sprays that you, if you just travel to endemic region, yeah, just apply spray on yourself when you go outside. Vaccination. Some candidates reaching clinical treats with short-lived efficiency. I mean, so yes, it's actually, the last time I checked World Health Organization site, it's written that vaccine available, but again, its effectiveness is not really high, so some studies continue to find something more effective. And so what should you remember, after these lectures? So malaria, endemicity and seasonality depends on mosquito habit, seasonality, and Plasmodium species. So in some, is called in countries with colder climate, it's summer season, and in tropical countries, the whole time. Resistance to medications is species and local dependent. If Plasmodium falciparum, assume chloroquine resistant at sectioned island of Hispaniola. Clinical. Who is at risk? How to differentiate severe and complicated malaria? Differential diagnosis. How to choose an anti-malarial treatment. AST are preferred therapies for all species in severe form. AST if oral, artesunate if intravenous. Severe malaria treated same regardless of species. And where to find up-to-date sources of malaria. Yes, up-to-date sources of malaria. Again, it's maybe CDC site, World Health Organization site. And if malaria is local in your country, probably you have your own recommendations. But again, use trusted sources, official sites. Well, in short, that's all for today. Some additional material, maybe again, you may use this like small book, like a short manual book from our department, which is available. You can ask your teacher, he will send it to you an electronic version. If you want to read it, again, it have short data about all the disease. Or you can use this book of World Health Organization, where it's written really detailed with all sorts of interesting things you may be interested in, and of course, treatment is up to date. Well, that's all. Thank you for your attention.